Okay, welcome to our first extension lecture of the series on health inequality. Um, I'm just going to give a quick timeline first of all, so you can see what's coming up. I'm chairing it. My name's Guy Shardy Beckett, and then we've got actually this running order is now incorrect. Oops, sorry, is now incorrect because Majid's going to go first, followed by Chris, followed by Sophie. But with those sort of rough timings. But the aim is to get through all the speakers one after the other, and then have a Q&A, and we'll finish promptly by 7:30. So that's the basic timeline. I'm going to give a quick introduction now about and talk about what these extension lectures are about, a few housekeeping things. Then I'm going to talk a little bit about note-taking, and then give a quick introduction to this particular topic. I ought to give an introduction to myself. I sort of founded the extension lecture program as part of the university preparation program about 5 years ago. And what we've done loads and loads of them now. And what we do is we take a topic and we invite speakers from all sorts of different disciplines to talk about the topic. And what we found interesting is to hear 3 or 4 different disciplines commenting on the same question. And that gives you a chance to see how academics think and to relate your thinking to their thinking. We think it might help you think about what subjects you want to study at university. It'll get you used to being in lectures and get you used to asking awkward, difficult questions of academics. And in fact, that's probably the thing we value most in the extension lectures, the ability to ask a question and be brave enough, being brave enough to ask a question. So we've got some basic housekeeping, which I think actually everyone in this now knows far too much about online learning. But if you could stay muted and keep your cameras off during the first phase, when we get into the Q&A, do please unmute and turn your cameras on, or unmute if you get called to ask a question. What I'd ask you to do if you want to ask a question is to send me a message in the chat. Just send it to me personally, Guy Shardy Beckett. And then what I'll do is I'll either clump them all together and say we've got a bunch of questions about X, or if you'd like to ask it personally, we'll call you in to speak directly. In fact, I mean, that would be the ideal, but some people are nervous about doing that. So just send me a message with what you'd like to ask. And what I'm going to talk briefly about now is about note-taking, and then I'm going to do a very, very quick introduction to the topic. All right. Now, this is not all my thoughts about note-taking. It's just a brief introduction to what I would do in this situation. So I would write down the names of the speakers, and then underneath each, and I'd kind of space it down the page, or if I was writing on a computer, I just put each speaker's name as a sort of heading, and then underneath that, I would have 3 basic subheadings: the main claims of the speaker that the speaker makes, any evidence that they cite, and then underneath that, my questions and thoughts about the things that they're saying. So I separate my thoughts from their thoughts, and I would then try and record fairly accurately the main things people say. And then if that strikes any questions or thoughts in me, I put that underneath, so I can clearly separate my thoughts from theirs. Underneath, at the very bottom, I would be trying to think out one really good question that I'd like to ask. You'll have loads of questions in your head, or you might do, or loads of thoughts, but I would be trying to have one question that I would like to ask. And it may be that I'd have a really good question for one speaker, or I might, if I'm really feeling smart, I might have a question that pulls together the thoughts of 2 speakers, or if I'm really lucky, I hit a question that I think is relevant to everything that everyone's saying. And that's when I think, when I'm in the audience, that's when I think, God, I've got a good question, is if I've got one that I think applies to everybody. but that's, I mean, at the beginning, any question at all is a great thing to have. That's what you should be aiming to be doing as you listen. So I'm going to just start thinking a little bit about health inequality. And what I've done to help us with it, I'm a historian by training, a historian of ideas. So I often use Google Books Ngram Viewer. And what that is like it searches live through everything that Google has digitized from the 1800 to the present day. And you can put topics in and see when those topics started emerging as topics in books. Books includes kind of things like magazines and newspapers, because they're collected usually in books as well. And as you can see, health inequality is a trending topic. It kind of really took off in the 1980s, and although there was a bit of a dip in the 2000s, it's really climbing again hard now. There's quite an interesting little kind of spike in the 1820s, and because I'm a historian, and that's actually my period. I was really curious to see what it was in the 1820s that people were looking at and thinking about in terms of health inequality. And basically, there were kind of two things that the term was that connected with that term, which is about improving the health of livestock and cattle, and the treatment of prisoners, and particularly about the cruelties of treadmills. So you can see there that there was a sense of managing people and managing things when people talked about health inequality. It was quite a kind of authoritarian topic in a way. Interestingly, if you put health inequality against health equality, you see that health equality lags some way behind inequality. So in a way, to me, that says that people are identifying the problem, but there's perhaps less of a sense of a solution. But we'll see what our speakers think about that. Obviously, inequality and health are not new things that people are concerned about. If you look at health inequality compared to general discussions of inequality, inequality has been a rising topic. I mean, it's been a huge topic since the 1800s and is an ever rising topic. But health is an even bigger topic, though oddly, it's been in decline since the 1980s as a topic of concern. I suspect that post-pandemic we'll see a massive increase in interest in health as a topic. But that's an enormous issue that masses of literature discusses. Okay, so the question we're discussing is how can we address the inequalities in health, both globally and locally? And I'm going to ask Majid from Imperial to kick us off. I'll stop sharing.
Thank you, Guy. And thank you for inviting me to this really, really exciting program. And I hope to see some of you at Imperial next year, at least, of the students who are involved. Let me just, before I actually mention a few things, also, is that for one thing, I hope you take a message from my presentation and perhaps the others that it just doesn't matter what you study. You can contribute to dealing with health inequalities and enhancing equity in health. You can be historian, as Guy mentioned. You can be a medic. You can be a mathematician. You can be, in fact, an engineer. Anything you study. The second thing, before I go through this, some years ago when I was teaching a class on global health, at the end of the term, a student came and said, "Look, professor, your class is really depressing. You just told us really bad things about health in the world." And it's actually very tempting when we talk about public health, global health, health inequality, to just be negative, and it's especially tempting when we are in a pandemic. But I hope that you take out of what I'll say and perhaps others that there's actually a lot we can do, and a lot of good things have happened in relation to health, while there has also been a whole range of things that are negative. So with those, I guess, themes in mind, let me go here. Can you see my screen?
Not yet.
Okay, sorry. Let me go and okay. So can you see it now?
Yes, we can.
Good. Okay. So let me just give you sort of a few, I guess, statistics. My entire research group works on data, and I'll come to that at the end. A child, these are numbers from the UN Population Division. So a child that's born in northern Nigeria, so sort of around here, is about 150 times as likely to die before she or he reaches their 5th birthday than one in Finland or Norway. So there, out of every 1,000 children, maybe about 2.5 on average, that are born die before their 5th birthday. In northern Nigeria, which is one of the highest ones that people have recently looked at, it's 150 times as much. And if we look at around the world, life expectancy, which is some measure of somebody born today, how long they're expected to live, it varies by about 30 years. That's a lot. That's a lot of time. So somebody in Central African Republic or Lesotho would be expected to live 30 years longer than somebody in Japan or Switzerland or Australia or Canada, some of the places that do quite well on this. These are large numbers. So this is the bad news. But on the good side of this, if we look at this over the past few decades, so at least until the pandemic, and we will see what the pandemic does, is that there has actually been a converging trend. So many countries throughout East and Southeast Asia, throughout Middle East and North Africa, so many parts of China, Thailand, Iran, Turkey, Egypt, many parts of Latin America, they've actually gained a lot more than Europe and America and Australia have. The situation hasn't been as good in Africa and in places like Afghanistan, Pakistan, that have had a fair amount of war, but some of the biggest gains have been there. And so places like Chile now actually completely outperform many of the other countries in America and in Europe. China and Thailand, again, have been doing remarkably well. So, and in fact, so well that some years ago, there was actually a report published, a commission called Global Health 2035. And the people who wrote these, who actually were quite prominent people in global health and thoughtful, they argued that it is possible to actually converge within a generation in measures like life expectancy. So the frontier is the country in the world that has always had the highest life expectancy. That country changes, but that's the sort of the highest we see. And they argued that many countries are actually approaching the frontier faster from the bottom. And I don't know if I can actually for a moment show my, I don't know, can you see the website that I just brought, or does Zoom not allow that?
Yes.
If you can, okay, if you can see that, this is from today's New York Times. So I actually happened to come across this. New York Times ran a really nice piece today for those of you who want to go online and look at it on actually child mortality and child survival and life expectancy. And it's a lot of photos and it's also text and in a really thoughtful way, and talks both about the large differences and this sort of increasing convergence. So that's when we look at countries. But the other side of this is that there has actually been increasing inequality within countries. So these are two numbers from England and from America. And here it's comparing, in this case, I think this is for females. It would be the same story for males. It's comparing, looking at a period of about 15 years and looking at, and the length of these lines are showing the gap between any group here, the worst off group, the most deprived group, and the best off, the least deprived group. And this gap over time has gone from 6 years to close to 8 years. So over a period of about 15 years, it's gone up by 2 years. That's a lot of increase. The 2 years increase in gap between the best and the worst off. And in America, in a longer time period, it was an analysis that we did. Generally, the inequality, so this is a standard deviation. This is a measure of a spread of life expectancy across different parts of the US. It was going down for males. It went up for a bit. That was probably some effects of smoking in the period between First and Second World War, then going down, then something happened in the early 1980s. So actually really something started in 1970s that it just went up. This didn't slow down during the Clinton or the Obama administration. It just kept getting worse. And this is getting noticed. You know what Guy mentioned. This is a piece from a British paper about the 10 years difference between in the UK, and this is a piece from an American paper, New York Times, that talks about the short end of the longer life, and it talks about the people who are doing really badly. So this is the background. So I was asked to talk about what can we do about it. It's tempting to say public health interventions work, and they do. But in fact, many public health interventions, even when they benefit the poor, they actually benefit the wealthy the wealthy groups more. So this is again an analysis from American data that a group of researchers looked at, going from all the way to the 1970s, when smoking in males had just started to come down and women was still going up, came down at some time later, all the way to sort of early 2000s, and this could continue. So they look at the percent of the population that smokes. It's going down in these are poverty quantile groups of poverty, and these are education groups. It goes down in every group, but actually the difference between the highest and lowest becomes larger and larger. It goes from 10 percentage points to 20, 30, 3 percentage points here, 11 to 21. So it's going down faster in the rich. And actually, anytime you hear about public health, keep in mind who can use this. So there are many things that are good for health, and they are probably good for everyone. A place that is more walkable, providing healthier food options, and actions that can reduce the smoking, and you can sort of go through these. But do the wealthy, do the better offs, do the more educated have actually more of an opportunity to use them for reasons that we will see in a moment. Some similar thing with medical interventions. So I won't go into the details of this, but one of the things that has been extremely influential so here I'm giving an example that actually has benefited the poor a bit more. One of the things that has been extremely influential in reducing deaths from heart attacks has been the ability to get people to the hospital and actually manage the heart attack really fast. And in England, heart disease, ischemic heart disease, so it's largely heart attack and acute and chronic. If these bars are green, it means that there is less inequality over time. If they are sort of purple or red, there is more of it. And as the proportion of people who have had this medical intervention, which now you can do in many hospitals in the UK, and as that proportion has gone up, in fact, it has become a more equal situation. But that's not the case for everything. So in fact, this piece that really is hard to read without really bringing tears to your eyes is the story of a driver who had diabetes. So in the NHS, a system that he didn't have to pay for care, he had diabetes complications, and he was told that he has to go and see his physician to his diabetes clinic regularly. And he started missing his appointments, because if he had gone, he would have actually not only not been paid for that day, but he would have actually been fined. So he started missing his appointments, and he died of diabetes complications. So even when medical interventions work, even when there is actually no monetary cost to paying for them, there are actually inequalities on who can use them. And so in many ways, I think one would say that it's really hard to use public health and medicine, both of them that can be really effective, without actually investing in people, in secure jobs, in communities. So this is a book written by Anne Case and Angus Deaton. Angus is a Nobel Prize winning economist. He got the Nobel Prize a few years ago. That they used America, and they actually used the language deaths of despair. They said that a series of phenomena, and some of them long-term loss of jobs, and some of them short-term cuts to various government programs, have created a state of despair for many people that has led them to be using to be having so-called behaviors, things like alcohol, drugs, use of medicine, and so on, that's actually making them die early. So um, so I put these slides together a few days ago. If I put them together last night, this would have been actually even more up to date. And we can see that strangely, for a change, the other side of the Atlantic, the new Biden, Harris, and Yellen. So Biden and Kamala Harris, but also Janet Yellen, who is the Treasury Secretary, they have been thinking about how do we spend money to actually make things better for people. They have announced 2 programs, and you can see again some headlines there. Biden wants to define his presidency by emphasis on equity. They want to give money to communities, and here is some examples of things they are putting money on. And I could have put more examples: affordable housing, public schools, public there would be state schools, water, childcare, a whole set of things that actually would be good for people and for communities. So, but there are examples of things that have worked. They're going to have put here an example from Mexico, a program called Progresa that actually, it was a really interesting idea. It actually provided cash to poor people, but not only did it give cash, and they argued that actually when the money goes to mothers of children, it's spent better, but the cash was conditional on the family doing certain things. So there was nothing, they didn't have to pay it back, but it was conditional on making sure that their children are actually seeing their physicians regularly, that there is certain actions that were good for health, but they also provided cash. And when this was looked at some years later, they actually found that there were benefits in terms of those children's growth and development. Down there is a program that actually was argued by somebody named Sarah Bleich, who is a researcher at Harvard. And actually now she's involved in the Biden administration talking about their food program. So the Supplemental Nutrition Assistance Program, this is what used to be called food stamps. This was programs that actually would help lower income families have access to food. And they have gone through all of the policies that we can do that are specifically targeting lower income people to not only be more food secure, but be able to actually have healthier food. So it is possible to actually have programs that are good for health. They're not bad for anybody, but they specifically target the poor. And strangely, this is not new. So Guy mentioned his internet search. This is a piece that was written in 1917 by somebody named Charles Chapin. He was at that time superintendent of health for the city of Providence. He actually really is one of the founders of modern public health in America. He became president of American Public Health Association. And Chapin realized that his city was spending all of its health budget on rat catchers at the time, which was a good thing, but there was a limit. And he went through a lot of systematic thinking he thought about medicine, he thought about epidemiology, he thought about economic issues, about political issues, and all of those, how they could work, and came up with a list of things that he felt his city can do to actually improve health, especially for the poor. So it involves healthcare, care for the sick poor. It includes things like food safety. It includes housing, plumbing, things that would be about childcare and infections, and so on and so on. So this is not something that actually has been just come, but I think to think poor has been around. It just has somehow gotten away from many of our policies. And perhaps the last example I'll give before one slide that I'll use to finish off is an example from Bangladesh. So Bangladesh is a very poor country. It also is a country that has a lot of income inequalities in it. But through a variety of ways, and one of them is actually, some of them is through the government sector, some of them is through really large and well-established non-governmental sector. They have managed to make their health interventions, be it public health, be it medicine, much more broader than those who can just pay for them. So this is coverage of immunization, and it has been remarkable how much it has gone up over time, and it's really reaching a big part of the population. So this was a series of 5 articles. I've just put the headings for the titles for 3 of them. So the Bangladesh paradox, exceptional health achievement despite economic poverty. Then they talk about community-based approaches and partnerships. So they talk about, how Bangladesh innovated in delivering health, and in many ways, the sort of things that we can learn from in the global north. That, how do you deliver services to the people who need it the most and can least get to it? And then finally, again, they go talk about sort of scale, how they manage to do this, not just in the small areas, but everywhere, and to do it in a rapid way. I'll end with this slide. So it's tempting to talk about all of the things we want to do, but I also want to remind you of the importance of data. So again, I have a research group that's people from a whole range of backgrounds, but many of those people are actually mathematicians and computer scientists and physicists, so very quantitative people. And a good part of our work is actually about measuring things that are around public health that are hard to typically measure, and among them is equity. So a lot of our data systems have traditionally been designed for good reasons, in many good reasons, but perhaps at the neglect of equity for representative countries as a whole, or provinces or states or local authorities as a whole. They haven't really been designed to sort of track people. They are there to represent administrative units. And what the cost of that has been, it's been actually really hard to track equity on a systematic way, and how it changes. And if you have a new policy, if you have a new housing policy, if you have a new school policy, if you have new medical interventions, if we reorganize the NHS, we have good ideas of what it does to health as a whole, but we actually are not very good at understanding what it does to health equity. So the other side of this whole study, this picture, is to actually to measure, to monitor, to both be able to better intervene, and also to be able to keep the systems accountable. So I've talked more than what I wanted to, but let me stop now, and then after the other speakers, I look forward to any discussions.
Thanks, Majid. That's really fascinating. I'm actually a historian of statistics and data, so there's a lot I want to ask you about at some point, but I don't think it'll be today. Hopefully it'll be students entirely asking questions. So now I'll hand over to Chris, who's going to talk, who's from King's.
Thank you, Guy, and thank you very much, Majid. I think that was a really, really helpful kind of backdrop to some of the stuff that I'm going to say. I think I'm going to take quite a different tack, quite a different approach. In that, first of all, I don't have any slides. I'm just going to talk. And secondly, because I wholeheartedly agree with all of the, you presented a huge raft of statistics. And as I said, I think that's really, really helpful, because I'm actually going to go straight for the jugular, as it were, and seek to address the actual question of how we can address inequalities in health, both globally and locally. And again, as I said, I'm going to take a slightly different tack. And the reason for that is that within the global health community, within the public health community, within politics, within high-level understandings of the relationship between politics and health, we pretty much know that across the board, solutions that tend to reduce income inequality, that tend to improve access to healthcare services, that tend to provide poorer people with access to healthcare services, but also poverty reduction, good housing, nutrition, safe water and sanitation, good jobs, all of these kinds of things. And actually looking at the impact of somebody like Michael Marmot, and what Michael Marmot has written about the social determinants of health approach, and the way in which this is actually the best way to understand the reasons underpinning health inequality. What I actually want to do is to ask a slightly different question, which is, given that we really do know this, that within the academic world we know this, and I would be happy to address any challenges to that statement, but I think that it's fair to say that if we're interested in population health at the global level, I'm going to be as blunt as I can possibly be. If we're interested in population health at the global level, the best thing that governments can do is do things that are much more broadly left-wing in terms of reducing inequality, in terms of income, in terms of improving access for the poor, etc., etc., etc. So the question I'm going to ask, which is a completely different question, but nonetheless incredibly important, is why do people vote for parties that promise that given the information that we have about the relationship between politics and health, that broadly the political parties that are most likely to give us lower income inequality, greater access to services, are more likely to improve population health as a whole. So just to give you an example, Majid mentioned, you know, what happened at the end of the 1970s in the Western world, that there was this increase in inequality, slowdown in improvements in life expectancy. And Michael Marmot has commented about the impact of on life expectancy in the UK since 2010 of austerity, the austerity policies of the British first Conservative-led coalition and then solely Conservative governments since 2010 in the United Kingdom. And what Majid said, one thing Majid said earlier on was, somehow pro-poor has got away from us. And that surely is the question we've got to be asking. So over the past 10 years or so, in the United States, you had the election of Donald Trump. In the United Kingdom, you've had successive conservative administrations. In Brazil, one of the most populous countries in the world, you've had the election of Bolsonaro. You've got Erdogan in Turkey. You've got Duterte in the Philippines. And all of these men, and they're all men, have focused on particular kinds of politics, which have tended to produce negative health outcomes in their countries, but nonetheless have been massive vote winners in their countries. Now, I'm not sure, it remains to be seen. Obviously, Donald Trump lost after one term. It looks like Bolsonaro is likely to lose after one term, the way that things are going in Brazil. But I think what we've got to ask is, ultimately, why do human beings care so little about health? Or they seem to care so little about health? What is it that influences human behavior, both in terms of the way we behave ourselves and the impact it has on our own health, but also how we behave at the ballot box? Why do we vote for parties that are less likely to produce the sort of gains that we can see in health? If we look in the UK, life expectancy improvement has absolutely ground to a halt. Why do we vote for those parties? And actually, I think that we have to go back and back and back and back and back and talk about, so Michael Marmot and the social determinants approach is very much, what are the causes of ill health? So we can look at that, and we may look at you know, viruses, or we may look at you know, accidents or poor health behaviors leading to non-communicable diseases. And then we do the causes of the causes. And the causes of the causes is things like poverty and things like lack of access to services and those kind of things. But the causes of the causes of the causes is the inequality that we see across the world. And why is it that, sorry, this might end up being a little meandering because, as I said, I haven't got any slides, and I try to make my talks kind of quite engaging, but I do sometimes sacrifice structure for trying to make the talk engaging. So what my question would be is, how have those parties of the populist right, been able to weaponize things around identity, particularly using very, very skillfully using the mass media to to weaponize questions around identity, to do with ethnicity, to do with immigration, to do also, I think, and this is a really, really important question with regard to responses to health inequality, to do with the existence of what we could perceive to be the deserving and the undeserving poor, that somehow there are certain kinds of people that deserve greater things, access to services, or they deserve our sympathy or our help more than other people, that somehow that somebody like Donald Trump in the United States, and to an extent Boris Johnson in this country, have been able to make this tacit argument that this is an argument that goes back hundreds of years actually into sociology, and Herbert Spencer in the 1820s, I think, Herbert Spencer, basically the argument being that the poor are poor because they're lazy and stupid. And actually this way of doing politics, that actually there's a huge amount of people at the bottom of the socioeconomic spectrum deserve to be there. They smoke too much, they drink too much, they do things that are bad for their health. And actually, Majid showed the cover of the book, the crisis of despair, or the diseases of despair, or deaths of despair. And I think that that's got a huge amount to do with it. The way in which people see their opportunities so constrained by the way that society functions, by the fact that people who talk in a certain way, have certain ethnicity or religion or gender, are denied opportunities, and therefore people's belief in their own ability to get out of that situation is constrained. They feel that they're stuck. And if you feel that you're stuck, you engage, historically, there's huge amounts of evidence for this, in what we call immediate gratification. So you drink and you smoke and you take drugs and you don't exercise and all of those kind of things. And the whole thing is all bound up together with opportunity. And the fact that if people see their opportunities constrained, if they don't feel they have a stake in society, if they don't feel that they have the opportunity to advance, if social mobility is very, very low, and social mobility in the United Kingdom and social mobility in the United States are very, very low by Western standards, the idea of the American dream, the idea that anybody who comes to the United States can succeed, is a myth. It is, if you look at intergenerational social mobility between a country like Denmark, which has a much lower level of income inequality, a much lower level of health inequality, although the Danes do tend to have pretty bad health behaviors, and actually Danish life expectancy is quite low. But just talking in terms of social mobility, it is so much easier to advance from your father or mother's social class to a different social class in Denmark than it is in the United States. And that is all to do with the whole idea of sharing and of having government policies that mean that coming back to the social determinants approach, everybody gets the opportunity to have good primary education. Everybody gets the opportunity to have good quality healthcare, ideally free at the point of use. Everybody gets the opportunity to be employed. And actually, one of the big changes that took place, so Majid mentioned the late 1970s and early 1980s. So in the UK, up to that point, we had a thing called the post-war consensus. And the post-war consensus basically held that the main purpose of government was full employment. It was there to give people jobs or to help people into jobs. And the Thatcherite, Reaganite, monetarist revolution of the late 1970s and early 1980s changed that, turned it on its head, and it said the key role of government is keeping down inflation. And actually that changed radically the role of states and allowed markets to come in much more, because alongside this philosophical change, so you've got this political change alongside a philosophical change, the philosophical change saying that it's up to poor people, it's up to the individual themselves. This, to me, to my way of thinking, quite a victim blaming narrative. It's the fault of the people at the bottom that they're at the bottom, not the fault of the fact that the opportunities available to people who are more likely to be richer, whiter, maler, older are not available to them. And so I told Damaris as we were setting this up, I think I might be a little bit political. I'm not sure I expected to be quite that political, but nonetheless, I think that everything that I've said is true. And I think that, that there is an absolute necessity, if we are genuinely interested in population health, if we are genuinely interested in reducing health inequalities, because ultimately, I'm not sure that all that many powerful people are, because they don't listen to the evidence. If you take a man like Bill Gates focuses his huge amount of money in funding other Western institutions to look at largely technological solutions to problems of ill health, when actually, when it comes down to it, the problems of ill health, more than anything else, are political. I think I'll stop there. Thanks.
Great, that's brilliant. The questions are starting to pour in, and I'm
not that surprised, I must confess.
Sophie, we'll pass the baton to you, and then we'll start opening it up to questions.
Thanks so much, Guy, and thanks everyone for being here. It's really lovely. I mean, I can't see you, but I imagine, you know, you're all there and eagerly taking notes as Guy showed you how. So a little bit of context about who I am and what I do. So I'm a professor of international politics, and I have experience working on the politics and governance of AIDS. I was in Sierra Leone during the Ebola response, looking at what militaries were up to. And in COVID-19, I've worked a lot on the gender response and the UK's role in global health security that led me into some very strange meetings with UK government. Now, the reason I'm giving you some context is if you want to ask me about any of that, you know, what's it like to go into these institutions in the UN? What do you do in these meetings with government? What do they ask you? You know, I'm here for you. So I want to give you the best experience of what we do as academic researchers, and you might just be really interested. I've also written on Bill Gates, not the conspiracy theories around him, but some of the questions around legitimacy in his role in global health. But we're here to talk about health inequality. So what I'm going to do is I'm going to first think about what drives health inequality, why it matters, and actually what's been done to try and address it on the world stage, before then thinking about, okay, well, what can we do about it, ending with what can you do about it today? Because I absolutely take Majid's point that often when you talk to students about health inequality and global health politics, it's really depressing and you can feel like you have no agency to do anything, but you can. So we'll end with that. So firstly, as Guy said at the beginning, health inequality is a really big issue, and it really defines what many institutions in global health prioritize. So the World Health Organization, which I'm sure lots of you have read about in the news this year, is the main institution of global health. And its whole mission is to allow everyone to reach the highest attainable standard of physical and mental health. And it prioritizes universal health coverage, health in all policies. It's become quite controversial in that sense, especially during the 1980s and the Cold War, where the US government thought it was a hotbed of socialism for suggesting you needed to have universal health coverage. But increasingly you see a rapprochement around that. And most people say, okay, actually health for all is a good thing, even though it's aspirational in many senses. So what drives health inequality? And I think Chris really covered this, so I'm not going to spend too much time. There's one hand, it's a behavior issue. It's all down to individuals. If we just tell them to make better health choices for themselves, that'll be fine. Increasingly though, particularly in public health, that's been quite rubbished. I don't think anyone in public health will still kind of back that without looking at the structural factors that lead people to make certain decisions. And those structural factors can be issues of poverty and wealth, which is the really big ones that both Majid and Chris looked at. But there's also structural factors such as race and gender, and how racism and gender inequality shapes who gets sick, who dies, who works in the health sector, and who mops up some of the consequences of this. I think heart disease is a really interesting one, actually. So Majid said that heart disease kind of went down when you narrow times from getting to the hospital. It also decreased when people started to do research into how women presented with heart attacks. So if you think about it, when you watch TV and there's a heart attack, it's sort of like, oh, you know, the arm, the heart attack. Women don't present with heart attacks like that. And that led to women being misdiagnosed for years by doctors. Said, oh, it's just anxiety. Oh, it's just something else. It's not a heart attack. As soon as they started looking into the question, they started to see that was the problem. So we can come and unpack that bit in a minute. So structural factors then of class, race, gender, a little bit of behavioural factors that are shaped by these structural factors. Now, why does this matter? Why do we start getting interested in health inequality? It was very interesting that this started to pick up in the 1800s, as Guy suggested. This is a time of mass capitalist expansion and the realization that you needed a healthy workforce. You need a healthy workforce to boost your economy in the world, to get richer, to build empire. Okay, so it was fundamental to capitalism and capitalist expansion. It wasn't necessarily that we believe everyone deserves a right to health. It was like, no, we actually need healthy workers. This idea from the 1800s persists today. If you ever hear Melinda Gates or Bill Gates talking about any aspect of health, they'll always say, if you have healthy people, they will return X amount of GDP to your country. This is really big in like the women's health sector. If you invest in a woman, she will therefore create X for your economy. It's always not just about health, it's about what you can do from the economy. This is both from the Gates Foundation's perspective, but you've seen it throughout the 80s and 90s by institutions like the World Bank. Now, you might not know anything about the World Bank. Why would you? I didn't when I was your age, but I think actually there is a lot of kind of lessons now happening on the World Bank in international development. I think my students tell me that about that a lot. So the World Bank is set up at the end of the Second World War to give long-term loans to certain key reconstruction and development projects. So it was effectively to rebuild Europe, even though it doesn't really do that anymore. In the health sector, it's quite controversial because in the 1980s, it introduced these things called structural adjustment policies that was to increase privatization in low and middle income countries. The idea is you take the state back, private sector flourishes. Didn't really happen like that, exacerbated inequalities. But I digress. That's the first reason then, healthy workforce. The second reason why health inequality matters is that health is a human right and we all have the right to live our best life. Therefore, this should be a kind of thing that we all have. The third argument, which is very topical at the moment with COVID-19, is this idea of global health security. You might have heard in the news this kind of idiom that no one's safe until we're all safe. So we have to invest in unequal societies where you see health inequalities to ensure that we're not vulnerable. That's why you see states investing in low-income countries over infectious diseases, such as Ebola, such as COVID-19, because you don't want that traveling to your borders. It's all about protecting the West from the rest, the global North from the global South. I mean, that's quite a crude way of putting it, but it's the easiest way of explaining it. So that's why it matters. So economics, health security, human rights, right to health, us all living our best lives. Now, there have been attempts, therefore, to address this. Obviously, when you think it's a problem, you've got to do something about it. We touched on structural adjustment and what the World Bank's done. You've also seen this move towards goals. So the Millennium Development Goals and the Sustainable Development Goals, which are the UN's approach to getting states to commit to what are the worst scourges in the world and how do we address them. So a kind of shopping list. Now, these led to really big programs, particularly on HIV and AIDS. So at the turn of the century, so around sort of turn of millennium, in 2000, there was so much money to HIV and AIDS. And someone like me who really cares about that thought, well, this is just great. But the problem is you started to see funding, so this is big aid funding, going towards really specific issues. So malaria, maternal mortality, without actually funding health systems. So not building hospitals, supply chains, logistics. It all went to those And remember, infectious diseases, predominantly, other than maternal mortality. Those things that the global north was interested in. If, like me, you go and sit in a Ministry of Health in any low-income country and you ask them what they want, it's very rare that they say, we want a $1 million AIDS program. What we want is health systems. We want nurses, we want doctors, and crucially, we want to keep them in the country. Because what happens is good nurses and doctors tend to leave the countries in which they're trained to go from low income to middle income to high income. So you have this huge brain drain from these countries. So this is a big problem that you have. Why are we not investing in health systems? Why do we always say we want to invest in maternal health, malaria, polio? That's because aid agencies want to show bang for their buck. They want to be accountable to the taxpayer, us, and they also find that health systems are just a little tricky. So if you really want to deal with health inequalities, what you actually have to do then is build health systems throughout the world. This allows you to be responsive to any emerging issues, particularly pandemics, build pandemic preparedness frameworks within that, but someone has to be willing to pay for it. Now, this solves the problem of having a baseline. So having a baseline system. You then got the question of, well, who pays for it? Should that be subsidized by the state? Now, lots of people say, yes, if health is a good, a public good, as in my health shouldn't detract from your health, it should be free at the point of access because we all think as a civilized society, we should pay our taxes to this end, then you need to get rid of issues such as user fees, health insurance, two things that are big, not just in the US, but throughout low-income countries. The growth of the private sector in healthcare has been quite significant. So you might think, okay, well, then the solution is we build these health systems, we make them free at the point of access, they are available to everybody, jobs are good and levelling up. That's going to address some structural inequalities. It does to an extent, but it doesn't when we think about questions of race and class. I want to give you a really shocking example. When we think about maternal mortality rates in the US among African American women are disproportionately higher than white American women. Now, this, for some of you, might be no surprise. You follow Black Lives Matter, you're very concerned about structural racism and racial inequalities. Now, this is for a whole myriad of reasons, but it is around structural racism. It's about the health sector and how it delivers healthcare for African American women, and how African American women's experiences of accessing healthcare may stop them actually going to, say, deliver in a facility to complain about health issues. The most prominent example of which is, of course, Serena Williams, who wasn't believed when she was experiencing severe pain during the birth of her child. Obviously, I'm a big Serena fan, so I know her name's Alexis, but that's a whole other issue. So this is a really big problem. Now, one way that that issue is battered away is like, aha, this isn't about race, this isn't about structural racism, this is about class, it's about poverty. It's not coincidental that the majority of not the majority of African Americans, obviously not, that you have a disproportionate number of African American women living in poverty. This is a poverty issue. If it's a poverty issue and it's about access to health insurance and who can pay for better healthcare, maybe that's something there actually. But let's compare it to the UK. In the UK, as you know, we have a national health system. And in the UK, Black women are 4 times more likely to die from pregnancy or child-related complications than white women. It used to be 5 times more, so we have some progress, but it's still 4 times more. So what do we do about this? Well, we acknowledge that structural racism, gender inequality, is as important as class, wealth, and poverty. We don't disregard it. And I think there's a growing movement now within global health to recognize that. And it is absolutely acute and has been brought to the fore on account of COVID-19. So those are the 2 things we can do. Let's start actually acknowledging and addressing structural inequalities, and let's build better health systems free to the point of access for all. However, this is my other bit. Problem is, a bit depressing, we're actually going backwards. So there is some glimmer of hope, but for every hope, we're reversing. COVID-19, before COVID-19, we knew that pandemics, health emergencies, outbreaks totally screw over the lives of women, right? It's never good. We know this from Ebola, we know this from HIV/AIDS, and the same has happened in COVID-19 around the world. It's threatening to exacerbate and reverse any progress on gender equality. In the UK, following the Saul report, we also know that there's no such thing as structural racism. We're just denying it. And those people who speak out against it are now being subject to severe trolling and threats. Also, let's have a look at funding of aid agencies. So it was announced this morning at the news that the UK government is cutting by 80% its funding to the UNFPA. UNFPA is the one agency within the UN that funds contraception around the world, access to reproductive health services. What else do they do? FGM, female genital mutilation, they fund that. They fund spaces for women's activists. And this is hugely worrying because the UK was one of the biggest funders to UNFPA. And since 2010 and 2017, maternal mortality has decreased by 37%. UNFPA was a part of that. So you cut that aid, you're going to see that going up. So the trend is going the other way. And finally, and this is where I'm going to say this is what you can do. If you want to look at how unequal health is and how unequal global health is, look at the COVID-19 vaccine, all right? The majority of COVID-19 vaccines that have been administered in high-income countries, the rich countries. Rich countries have bought up, I just checked this actually, where's my data, because I always forget stats, have enough to cover 245% of their own populations. There's a surplus. Here in the UK, we have a surplus of vaccines to cover us twice over. We've bought them all up. What about other countries? So where do they get to buy them? Now, funny enough, there is a mechanism that helps low-income countries access vaccines that allows vaccines for 20% of a country's population, regardless of the ability to pay. Well, that's great, isn't it? We're going to give these vaccines away. I mean, at the back of the queue, let's just sort ourselves out first, that is rolling out through this scheme called COVAX. Now, that's charity. It is what it is. And it only covers 20% of the population. That's not nearly enough if you're going to vaccinate everyone. What's more, though, why don't they just release the manufacturing, the tech transfer, and the intellectual property that goes into the vaccine so people can make their own? Now, some people are like, oh, no. Intellectual property, super important. The pharmaceutical companies, the inventors that came up with the vaccine, they came up with it. They should be able to recoup the cost of it. They put in the research and development. However, that research and development was also funded by us, the taxpayers. So what do we want to do with that money? The other issue is this has happened before. So during the height of the HIV and AIDS crisis, antiretrovirals that you take for HIV to control the virus, to stop it becoming AIDS, was, I think, 4 times more expensive in South Africa. Don't quote me on this, again, rubbish with numbers. But let's just say much more expensive in South Africa than it was, that was having this huge epidemic, than it was in Europe and the US. 4 times. This is a country that is a middle-income country, how it's facing this huge epidemic. So they decided to say, right, well, you know what, screw you guys. We've got a massive disaster. We're going to import generic medicines from India, even though it's under patent. What are you going to do? Sue us? Well, yeah, 39 pharmaceutical companies did try and sue the government of South Africa. And guess who won? South African government. This then led to an amendment within the WTO, the World Trade Organization, to say in instances of health emergencies, states can issue compulsory licenses, i.e. they can make it right to manufacture the vaccines or treatment, so in this case ARVs, in their own countries, or work with manufacturers and others. It's in the rules. So if you were really concerned about health inequality, the biggest issue today in the world is vaccines. And if you want to act on this, I would really recommend you look into the people's vaccine and start putting pressure on the government to really not just give up surplus vaccines, not just to say you can have our leftovers, not just to say have charity, but allow countries in low and middle income countries in particular to manufacture and distribute their own vaccines. Thank you.
Brilliant. Thank you very much, Sophie. So if all the panelists stick their cameras back on, and then we'll kind of become a grid. Great. And we've got masses and masses of questions that have poured in. What I'm going to try and do with this is call people in to ask their questions, and I'm going to ask you if you sent me one already, and you've written like a big long paragraph, to try and turn it into a relatively short question. It'll be easier for the panel to answer it, and we'll get through more as well. So, Brooke, do you want to kick us off, please, with your question? Brooke.
Yeah. My question was, do perhaps people vote for these parties as a result of a lack of education about these parties and their history and their plans for the future, especially with people that have just entered the country for the first time?
So I think this is addressing particularly Chris's point about why do people vote for right-wing parties?
Do you want me to try and answer the question?
Yeah.
Right. So the question, I think, was why do you think that people vote in ways that are not necessarily in their self-interest or in the interests of public health?
And he was very interested in you relating it to education and migration. And so a lack.
Okay. So I think that when people go to the ballot box, they hold a huge number of different factors in their head that will lead them to vote in particular ways. And I think that there has increasingly over the past, I don't know how long, decade or so, been a increasing role for identity politics. And when I say identity politics, what I actually mean is to do with setting social groups up against one another. And the idea that very much an us and kind of an us and them argument that actually by voting in a particular way, we can ensure that the greatest beneficiaries are hold on, I'm not sure quite where I'm going with this. I'm going around in circles a little. I think that that people have been encouraged quite a lot by the mass media to vote in ways that are not to do with kind of rationality, not to do with what can actually benefit them, but to do with, it's almost as if these days politics is more about not what's good for me, but what's bad for the person that I don't like. Like, I really think the internet is quite a negative influence on this. And I think that our politics is becoming very, very polarized, such that people, it's almost like politics has become like football. If my team does something, then I'll cheer it, even if I don't really agree with it. And if the other team does something, like the pragmatism of politics that we used to have seems to have gone out the window. And it's very much more like there's a huge amount of us and them in terms of the way that arguments are structured. And I really think that the internet is a force not for good in that situation.
Great, thanks, Chris. I'm going to try and move on to more questions. We've got loads and loads of questions, so we'll sort of spread them around the panel as they come in. I'm going to ask two members of the audience to ask their questions now. Poppy and Freya both sent me questions about gender, and I thought it'd be kind of interesting to hear them both. And maybe well, let's see who either Sophie or Majid can tackle the question. So, Poppy, do you want to kick off first and ask your question?
Hi. So I was just talking about how Chris mentioned between the Denmark and the USA, health inequality and class mobility. And I thought a big role that could have done that is Denmark actually has a female prime minister. Not sure how to pronounce her last name, but her first name is Mette. And I think because of that, she has a different perspective and she can see the inequalities in health, as Sophie mentioned, that are very large in women, especially in mental health diagnosing. And because women talk to each other about a lot about health more than men in society, because men don't, due to fragile masculinity that is from patriarchy, but women talk to each other a lot, so they'll know their friends and their companions' struggles, like whether they be women of color, whether mistreated. So I think, would more female leaders lead to better health equality?
Great question, Poppy. And Freya, can you ask, your first question touches on a very similar topic, so do you want to ask that one as well?
Yeah, so I was wondering if we can consider insufficient health education in school as a factor of health inequality, specifically regarding sex and gender. For example, you could argue that health education for girls is quite inadequate because a lot of young women will leave education not knowing about common conditions such as endometriosis and polycystic ovarian syndrome, and therefore won't be equipped with the language and terms they might need in order to go to a health professional and then get the diagnosis that they deserve to have in order to get the proper help.
Okay, Sophie or Majid, Sophie's waved her hand first.
Yeah, I'm happy to take both because they're both excellent questions. So I'll take Poppy's question first. And do you know what, Poppy, this is something that I've been asked lots, actually, particularly with COVID-19. During the first wave, everyone's like, well, look at New Zealand, look at Germany, look at Taiwan, female leaders, they're taking action. Is it because they're women? And I think there's a tendency to possibly overstate this case. Because there's a big debate within feminism around, do female leaders actually represent female issues or interests? So every time you have a kind of small sample, there's always someone else. Classically, Margaret Thatcher is often the example that comes out in the UK context. The problem is there are so few female leaders in the world, we don't actually know. And then also it's too soon to judge. So if we look at someone like Angela Merkel initially was successful because she's Angela Merkel and she's quite a prominent leader in many ways, but now Germany's response is a bit more mixed. So I'm always reticent to say who's doing well and who's doing badly in a pandemic because it just switches quite often. But your wider point though comes to this debate around the ethic of care. Do women intrinsically care? And therefore, if they're in political roles, do they think about care roles and things like that? Or do they just come with experiences? So I think if you haven't read it already, I think Caroline Criado Perez's book, Invisible Women, which I think I've got somewhere. Oh, look, props. That was handy, wasn't it? She makes this argument. She's like, if you get more women around the table, these issues are going to be raised. I'm a little bit cautious about that because I think it actually positions women to always have to solve the problems. So it says, okay, well, women are just going to mop it up and sort this out. And why should we? Like, why can't the men work out to talk to each other and care? And also it reproduces gender stereotypes. Women, care, talk. Men, military, hard issues, economy. And I think we need to kind of break some of those tensions. But it's a really thriving debate. And so a really, really great question, Poppy. Coming to Freya's question, simply, yes. And this is, again, a real big issue within women's health, and particularly related to the question I raised around UNFPA, the UN Population Fund, who fund lots of money in comprehensive sexual education. But of course, there's a split. As you know, some governments, particularly populist governments, one thing that unites populist governments is they want to restrict sexual reproductive health rights. And they also want to restrict comprehensive sexual education. You know, don't talk about porn, don't talk about self-esteem, don't talk about safe abortion, because that's just going to lead to girls going out and doing this, which we all know is rubbish. So absolutely, fundamentally, you do have to have comprehensive sexual education. But really important for young women to have agency, and men and non-binary people to really have agency over their bodies. But it's also really vitally important that health systems and health structures also educate themselves. Okay, so it's got to be both. It's, you know, we've got to push back a little bit about this kind of Sheryl Sandberg, lean in, advocate. That puts all the emphasis on the individual. Why don't we have health systems that are better at recognizing female pain, such as female pain and issues like endometriosis that's been really badly under-researched? And I think I've got another book somewhere about that, but I'll dig that out in a minute. Thanks.
Great, thanks, Sophie. So Abby Denby's got a question for Majid, and also Charlie O'Brien. I think your first question that you sent to me could relate quite well as well to that. So Abby, do you want to ask your question?
Yeah, hi. I was just wanting to ask if the Mexico model that you showed us on the slide worked so well in Mexico, why isn't it used more often across the world?
Great, thanks. And Charlie, do you want to ask your first question? Charlie? Never mind. Let's go with that one. So.
Sure. So Abby, for somebody who is an empiricist, I think that question is close to my heart. So why don't we do it more places if we have evidence that it works? Actually, people have done it in more places, and it hasn't worked everywhere. So they then went and asked, so why did it work in Mexico? Mexico wasn't the only place. It has worked in other places, and not elsewhere. And it came down that program, the Progresa program, was really designed for a particular context in Mexico. So Mexico actually had a reasonably good healthcare infrastructure at that time. It didn't have universal insurance, but it does now. So it had a good health infrastructure, but certain groups of people were not using it perhaps as much as they could have. And beyond that, it comes down to often sort of the opportunity to use or the ability to use, and also they happen to be poor. So in the case of Mexico, there were many pieces there, and it really became this sort of, if you wish, double benefit of bringing money to where it was most needed, and also enabling and encouraging and through that what's called conditional cash transfer to use it. If you don't have a good healthcare infrastructure, then that's not going to be good, and that's one example. So in many ways, I think the lesson of Mexico was that a group of actually clever people. This hadn't really been tried. It was Latin America was where these sets of programs first began. A group of clever people sat down in a sort of almost engineering way and said, look, what's the one lever that we can change here to actually sort of provide benefit to a large group of people? There are other examples of other types that have worked. In fact, in South London, Ingrid Wall from King's College, so a colleague of Chris's, is working between schools and clinics to actually improve childcare. So I think it's as much the sort of the thinking behind the program of how they filled the gap that was needed as the specific of it.
Brilliant, thanks. Now I've got Marika asked a question for Chris, but actually I think this is quite one that's probably relevant to absolutely everybody. Would you like to ask it, Marika?
Yeah. So just a small question. So Chris posed the question of why citizens care so little about public health policy when voting. So for everyone, I guess, how far do you think that the events of this pandemic will impact voting behavior in the future?
Crystal ball time, everybody. Chris, do we first?
Yeah, okay, thanks.
But also, let's try and keep it brief so we can keep moving.
Yeah. Absolutely. It remains to be seen. I think there's a very, very interesting parallel with the end of World War II, with the fact that was a very specific historical moment, and people in the UK responded to that by voting for a left-wing government that gave us a welfare state. Whether that will happen in the United Kingdom in 2022 or 23 or whatever, or across the world, it's impossible to know, partly I think because of a load of the stuff that I've been saying about the polarization of politics and the role of the internet, and the fact that so many people seem, if you look at the where the Tories are in the polls, it does rather raise the question, what would they have to do, for them to go down when the government has done so poorly in its COVID response, and yet 40% plus still say that they're going to vote for them. Can I just make one very, very brief point as well in response to Poppy's question? I think that it's really, really easy sometimes to take particularly countries in Scandinavia and see them as being really like perfect, but actually Denmark in particular has lots of policies that are very detrimental to non-white Danes, and actually some policies that are actually outright racist, in that there is a thing in Denmark called a ghetto, which is actually the name of it. And if you live in a ghetto, then and you are charged with a crime, you are liable to receive a sentence or a fine, which is 1.5 times anybody else. And one of the ways in which you define a ghetto is proportion of people who are immigrants. Therefore, that is a de facto racist policy. So it's really, really, like, there's so much complexity to all of this, that when countries are doing some things really, really well, we need to take a bit of a, drill down into the politics and make sure that, we understand all of it, because there's an awful lot of other stuff which is going on. I think Denmark is really, really great for white Danes. I don't think it's quite so good for other people.
Actually, and that's brilliant. What I'm going to do now is just hold that thought about what the pandemic's doing, and tackle on another thought that someone's just had. So, Tafani, can you ask your question? It's very relevant.
Yeah, I was just asking, how do we address the biases in medical education? As I've read that it often leads to misdiagnosis, particularly in the Black and ethnic minority communities. And I was wondering if an issue worth thinking about is the fact that there's actually a lack of trust due to this misdiagnosis, and if so, how we would go about building the trust up between Black and other people of color and like the medical community.
Okay, I'm going to answer Tafani's question, but I'm just going to quickly answer Marika's question as well. So citizens care so little. Citizens vote for the economy, not health. That's the standard idea. However, the contrary to that is Trump. Why did Trump leave office? And I think the COVID-19 response was big, but the thing with, say, the UK context is vaccines. Obviously, we're seeing the vaccine bump, and everyone's like, well, we've got the vaccine, so this is great again. So it'd be interesting to see if that changes. But my fear is actually the economy and how the recovery happens is more important than how many people died and how the pandemic was mismanaged. Tafani, that is such a great question, and one that, again, I've been asked quite a lot around vaccine hesitancy and racism within the healthcare sector and a lack of trust. So the simple answer that people always say is you work with the community, you work with community leaders, you sort of build trust on that part. But again, that's putting the emphasis on, for example, Black people to solve a problem that isn't their problem to solve. It has to be solved within the medical establishment. I think one of the positive things that started to come out of Black Lives Matter is you're having a much more open discussion of these questions in big, prominent medical journals like The Lancet, BMJ, who are actually using the term structural racism. And I think that is vital, because otherwise, when you have something like the Sewell report that says it doesn't really exist, you're kind of just gaslighting people and saying, no, there is no racism, when every day you have these kind of experiences. So I think the government also needs to change tack as well, and that is going to be a concern. But I think it has to be sort of focusing on medical education, training and awareness. And I think if you look at the UK, for example, in contrast to the US, which is so much further down the line on these issues than we are, you are seeing the start of something. So I think there's a long way to go, but I think you're seeing demand for it, awareness of it, and therefore slowly some changes. But absolutely, I think the government also has to say, we're not making this up. And hopefully the combination of COVID-19 and its disproportionate effect on ethnic minorities in the UK and Black Lives Matter will actually start to produce some transparency over this. And there are also some really great groups that are doing a lot of advocacy work. So 5 times more around the maternal mortality issue is a big one. And there's sort of, it's not going away.
Now I'm going to call in Artiola, who has a truly brilliant question that I'm going to throw at Majid. Artiola, if you're there, if not, I'll ask it for you. The question is, do you think that a fair and strong healthcare system just can't work under certain ideologies?
So, I tend to be, as somebody who is not a medic, I tend to actually have a lot of positive things for medicine. I think in many ways a good healthcare system can work well, but But you are right that under certain ideologies it will be hard. So in fact, this is not unrelated to the question of biases in the healthcare system. So I actually am, my family moved to Canada. I'm a first generation immigrant, and it's actually, it's around race, it's around ethnicity, it's around language, it's around culture. There is a whole set of things that make healthcare difficult. So I think there is two components to it. One is related to ideology. The other one I'll get to. So if you talk, when I talk to my colleagues who are medics, they say, look, we really want to actually talk to our patients, and in some sense, especially in hospitals, it has just become hard to do that. So physicians read charts. Physicians don't talk to patients, and times are limited, and the hospitals have become administrative units. They have got bottom lines. They actually have to be viable financially. This is the language that's used. So hospital trusts and GPs have to be financially viable. It's not that they got to deliver the best healthcare that they can. And a good friend of mine who is a medic and a researcher, he actually did a study, and he just found out, it was as simple as this. Physicians looked at the chart, and he had randomized, this was experimental. Half of the physicians would go into the room and just look at the patient and talk to them for a few minutes. The other ones wouldn't. And the ones that just walked in, they had exactly the same medical information. The ones who actually went in and talked to the patients, they actually made better decisions about the patients than the ones that they didn't. And yet it's actually really difficult for physicians to do it. And so a part of this is actually sort of ideology, but also administrative systems, bureaucratic systems that have made it. But the other part of it comes down to one word, which is to one phrase, which is diversity in the medical community. So in fact, I mean, in some sense, actually, around issues of gender, but around a whole set of other things, a more diverse body actually has better discourse and makes fairer and more and generally actually more effective decisions. They make decisions that reach to a broader group. So let me end it with actually the purpose of this whole webinar, which is that it's for you to go to university. So go for it and actually become the doctors that the physicians and the hospital managers and the chief executives of the hospitals that actually bring the diversity. Diversity can be ethnic, racial, economic, to the workforce, and actually make the better decisions. So I think it's both the sort of economic system, administrative structures, and lack of diversity in the health workers, health bodies that are there.
I'm going to point out an irony in something you've just been saying, which is that you say that actually people make worse decisions when they're looking at the data rather than looking at the patient in front of them, or only look at the data. And there is something very interesting about the effect of data on decision making, and in the wider political sense, there's a similar thing that happens, I think. And one of the things we're taking for granted is a certain thing about data targets and health, which we could talk about at more length. But I'm going to, I'm not going to, that's one of my hobby horses. I'm going to try and stay off that one.
So I wouldn't want my doctor to make a decision about me without data, but I would want them to also. So I wouldn't want it to be just based on sort of some machine measuring. I mean, I would want the combination of the two to be there. But anyhow, that's.
Yeah. Farron's got a question about funding, which I think is quite a long question, but would you like to try and ask it, Farron? I will ask it for you then. So one of the common themes surrounding health inequality is the ways in which government fund their health systems. Do you think coronavirus will lead to large changes in the ways in which governments fund?
I mean, I think Sophie has mentioned this too, and Chris has mentioned it too. I don't know. I mean, I think we could come out of this pandemic going back to the post-war mentality of we are in it together, and I'd like to think. I mean, I actually used to live in the US, in America, and I partially left because I wanted to be in a place that at least the health system was more equitable, but a whole set of other things at the time that I left, and I mean, that was one of the reasons for not wanting to be there. So Europe and the idea that that's more accessible with its inequalities, and I look now across the Atlantic without being too enthusiastic. A lot of good choices are being made there, and arguably other places. New Zealand has started off well, but also making good choices, and some other countries are coming out of this, remembering that we are in it together. But it's not just we are in it together, but also more investment in infrastructure, more investment in housing, in schools, in health system. There is the other side that says that it will actually make worse some of the issues that Chris alluded to, which is polarizations, angers, and I think again, to turn it into action, it is up to us collectively as citizens, and for all of you as in the next couple of years you will be university students and rising leaders in your fields, whatever they become. To actually not forget the lessons of this, and say that, look, we got to make this change. Some of that is through information, some of it is through protest, some of it is going to be through actually technical work, technical in a broad sense. So I hope we come out of it for all of our sakes, issues like this, with more action oriented and more cohesive, but we'll see.
Sophie.
I think it depends which state you are in the world. So if you're an aid-dependent state, your health system is in trouble. So you could say that this is going to have people realize the interdependence of vulnerability, that we're all vulnerable to infectious diseases, therefore you have to strengthen health systems. But you're also seeing some states, like the UK, cutting their aid budget. So if you're a low-income country and you depend on aid to fund your health system, either that aid's going to be cut, or if there is investment in that health system, it's going to be invested in pandemic preparedness. It's not going to be invested in, say, nurses, doctors. It will go to those issues of trying to stop future pandemic flus, future global health security threats. And that is going to distort these health systems towards those kind of agendas rather than your kind of bread and butter public health concerns. And that's a really big thing to watch. And that's a really big concern around that. I also just want to add one quick point to the diversity issue that Majid pointed out. Actually, the health sector, hugely diverse. Majority of healthcare workers in the world are women, yet gender inequality still persists. So we do have a kind of representation issue. Diversity is always good. I'm not against diversity, but there are tensions there. And finally, I just pulled off my shelf another book, Dorothy Roberts' Killing the Black Body, that you might want to check out. It's 20 years old. It's set in the US. So I'm expecting you to do a PhD and make this more UK relevant. Come and look me up in 5 years, and I want a signed copy.
Brilliant. Chris, you're muted. You're currently muted. Chris, you're muted. Chris, we can't hear you.
Sorry. Should have learned that by now, shouldn't I? One word we haven't mentioned, which is a really, really important word, and which is something that clearly we've got 2 minutes left and we can't go into in any detail, but all of this is about power. All of this ultimately is about power and who has the ability to influence the way in which these things happen. And so much power is invested in money, and so much money is in the hands of so few people, that this, to me, is what underlies all of this inequality, is the ability of money to supersede, to money becoming more important than people. And that's the key issue, I would say.
I mean, I'm Foucauldian. I tend to think everything's about power, but I think that's right. I mean, I was thinking about what Majid was saying about the history of vital statistics. They go back earlier, they're 17th century or earlier in Britain. And they were there at the beginning, they were connected with war. that basically, like, the wealth of a country was connected with the number of people you had in the country, because that was the number of people who would fight the country. So France had a bigger population, so scared Britain because it had, you know, potentially a larger army, and there's always been a power question at the heart of this. We haven't got time for it now, but I think a really interesting question is whether, you know, like Malthus broke that connection between population and power and said, you know, bigger populations lead to poverty. And we are definitely facing an issue now with environmental catastrophe and growing populations, that it's not automatically a social good that you have a healthy population even. But that's not a question that we can deal with today. I'd like to thank our panel, who've been absolutely fantastic. And more than that, I'd really like to thank our audience, because you have asked some absolutely amazing questions. And the first year that we did this program, no one asked any questions at all at the end of the first extension lecture. So I think this has partly been a testament to online learning, that everyone's got used to it and is good at using the chat. But I think you've also asked really, really interesting questions. So thank you all very much, and see you all next time.
Thank you. Bye.
Bye.